Hi, everyone. Welcome to episode 9 of the Comprehensive Review of Dermatopathology. Today, we're going to cover tumors of cutaneous appendages. So the appendages are really our ducts and our hair follicles in our skin. So the most important thing you need to decide when you see one of these tumors is, am I seeing something that makes ductal structures and fluid, or am I seeing something that makes follicular structures or keratin? So a list of hair follicle tumors we'll cover are things more in the hamartomatous category, such as folliculosebaceous cystic hamartoma, Fibrofolliculoma, Trichodiscoma. And then we get a little bit more well differentiated into trichofolliculomas, trichoadenomas, trichoepitheliomas, trichoblastomas. And then, of course, the malignant version of these is like a basal cell carcinoma, which we've already covered in another chapter. And then sometimes people put panfolliculomas and pilomatricomas in the cyst section. You could also put it in the hair follicle tumor section. That's if you want to focus more on the tumor part of it or the cystic part of it. And I've included them here. Tumor follicular infundibulum, and then a few more rare carcinomas such as trichoepithelioma carcinoma and a matrical carcinoma. Then we're going to cover some sebaceous neoplasms, which are not very well defined, but we'll give you kind of a general guideline of how to approach them. And then we'll talk about sweat gland tumors. And so you have just the more pure cystic things, and then the benign monomorphous tumor-like things in the poroma, sporadinoma, cylindroma, hydradenoma categories, the more papillated things like syringocystadenoma papilliferum, and the hydradenoma papilliferum, which it looks like. And then we'll move on to the malignant sweat gland tumors. And that will be it. So just as a review, in the skin, we're going to kind of look back at the hair follicle and all the different sections of the hair follicle. So this was the infundibular portion of the hair follicle that recapitulates the epidermis, has a granular layer, cornifies to basket weave orthokeratosis. This is the part of a follicle we call the isthmus. You see that the cells are a little plumper and a little paler than in the infundibular portion. This is where our sebaceous lobules insert. This is where our piloerector muscles insert. This is the section where the bulge and the stem cells of the hair follicle reside. Moving a little lower, you get to the tricholemal portion, and now you're starting to get this very pale color filled with glycogen. And then you're in the matrical portion of the hair follicle, the very blue portion. Okay. Looking up close, this is the matrical portion, that was the infundibular portion. All right, so let's start with some definitions. What is a hamartoma? A hamartoma is an overgrowth of tissue, a whole area of tissue that kind of looks a little funny. It's aberrantly developed, but it's overall normal, and it includes all the surrounding elements as well. When we talk about an adnexal neoplasm, like let's say we're talking about a follicular neoplasm, that's a benign adnexal tumor. Well, we're really talking about a structure of the hair follicle that kind of gets overgrown or overdeveloped almost in a tumor-like fashion. And then when we're talking about a malignancy, like a basal cell carcinoma, you're really talking about like one mutated cell that's sort of clonally proliferating. So folliculosebaceous cystic hamartoma is actually a descriptive name for this type of hamartoma, and certainly these can be arranged in different ways and they don't always fit into a category. So as long as you can identify you're looking at a hamartoma, that's really all you need to be able to do. You have a central cyst here with radiating sebaceous lobules, and then the stroma around it is kind of overdeveloped, and you have different elements that you have in your skin, such as adipose tissue, vessels, neural tissue sometimes. If it looks very spindly and wavy, then sometimes they're called a neurofollicular hamartoma. So as you can see, this would be normal hair follicle, normal collagen, and here you've basically taken this little area and blown it up like a balloon. And it looks a little bit exaggerated and caricaturized, but your follicle is really dilated, but otherwise it looks fairly normal. Your sebaceous lobules are dilated and there's too many of them, but they kind of come off in ways that resemble normal. You can even see here there's a split in your stroma, and your collagen is also overdeveloped alongside the follicle, and you have all these little white spaces. You might have a little bit of fat, you might have a little bit of extra blood vessels. So it's basically like you took a section of skin and you blew it up and made it a little funny looking. That's my very technical definition for a hamartoma. Okay, so this is a little bit up close. You know, all the structures are normal. The sebacites are normal. You know, the follicular structures are relatively normal. They're just kind of arranged in an unusual fashion. So fibrofolliculoma and trichodiscoma technically fall more into this. There's sort of an in between a hamartoma and an adnexal neoplasm, but they're basically the same type of lesion, but if you cut them in different directions, you may see more of an emphasis on the follicular part or more of an emphasis on the stromal, fibrotic, dermal part. And we, of course, know about these being in the Birt-Hogg-Dubé syndrome. And the reason they're both in there is because they're probably cuts of the same lesion that look different. So in this particular one, you know, centrally, the collagen with a little bit of fat in the vessels is really the highlight of this. And you can see you have like a little rim of follicular structure. Sometimes they're even bigger and dilated, but they surround this kind of collagenous area. So this is what we refer to more as the trichodiscoma. Okay, and you can see here, you've got a little fat, fibrosis, right? Increased collagen, increased fibroblasts, some, you know, abortive hair follicles that are not quite formed, but still within the realm of normal. Now here, centrally you have a follicular structure and peripherally you have that dense collagen, and it looks sort of like a normal follicle, but sometimes you have funny little arms coming out. This is the way a fibrofolliculoma is arranged, okay? But you can imagine if you turn this 90 degrees to the left and cut it, this might be on the side and you might have a central area of fibrous tissue again. So, you know, it depends on how you cut it. You have to remember things occur in 3D. But when I see a follicular structure that's a little bit funny in the middle and has little arms coming off, sometimes you have multiple of these little arm things coming off, that's when you call it a fibrofolliculoma. Here's another look at a trichodiscoma from the side, where the ball of collagen is more prominent. All right, so the next step towards an adnexal follicular neoplasm is a trichofolliculoma. This one's sort of intermediate differentiation. And here, rather than kind of a vaguely normal looking follicle that's dilated, you have little baby, almost fully formed follicles radiating off of a cyst. So it's a little bit more complex of a proliferation. Again, you have a fibrotic stroma. Almost every follicular neoplasm has a fibrotic stroma. What differs between them and a basal cell carcinoma is basal cell has that fibromyxoid stroma. This can have sebaceous differentiation, right? Because the sebaceous glands ultimately do enter into the follicles. So it just kind of depends on which section is over proliferating. But here you see the central cyst, and then you see all these little baby hairs come out. I mean, these are not like reedy ridges, so sometimes people mistaken this for like a dilated pore of Weiner. But a dilated pore of Weiner is basically an infundibular cyst with reedy ridges. These are little baby hairs that are coming off. You can see that you've got almost a matrical portion of a hair follicle. Sometimes you'll even see, you know, inner outer root sheath and a little tricholemal portion. So mama and her babies is what it's been called. See here, it's a little bit more complex. These are palisading basaloid cells. And then you have a little bit of infundibular stuff. Sometimes you'll have a little bit of the pale tricholemal stuff. So it's more complex than the hamartomas. This is that same lesion, but kind of turned and cut in a different direction. So here you lose that cystic quality, but you're able to appreciate more how, see, these are follicular structures that are fairly complex. You see all the layers of it down to the matrical portion, including a hair shaft even. Here you have that little horseshoe matrical portion. Okay. So then moving onward, we have a trichoadenoma. In this case, you have keratinous cysts with an infundibular lining, and you have a fibrotic stroma. Now we've kind of entered follicular neoplasms, okay, benign follicular neoplasms. So these kind of look like just milial cysts in the dermis. Your main differential for this will be milia, right? Milia in a scar or something like that, or Favre-Raccouchot, where you might have a bunch of milia. And so in that case, you would have a bunch of solar elastosis in the background of this tumor, whereas if this is a follicular neoplasm, then you're going to have a more fibrotic stroma in the background, the way you do with other tumors. This one's kind of hard to see. I don't think it's stained very well. But this is what a trichoadenoma looks like. And then, of course, in this adnexal neoplasm section, what a lot of people find frustrating is that a lot of it's memorization. So I kind of want to give you a general approach, but eventually you're just going to have to memorize a different pattern. So these are all these little milial cysts, and you can see it's an infundicular type of lining, right? Like the top of the epidermis, and you get your cornification. So trichoepithelioma is a little more poorly differentiated. That means it's heading towards being like a basal cell carcinoma, right? Or towards something more malignant. And in this case, it's the hair germ. So what you're really doing is you're taking that matrical portion of the hair follicle and you're replicating the structure. That's your papillary mesenchymal body, as opposed to sort of replicating all of the follicular units or, you know, a whole section of skin. Now you're replicating just one structure. And so you'll get these islands of basaloid cells with the peripheral palisade, right, because of the follicular origins of it. And you're going to see these papillary mesenchymal bodies, which are going to remind you kind of that horseshoe matrical portion of the follicle. It'll still have a fibrotic stroma. You might see calcifications. And then you, of course, have this desmoplastic variant where then it looks completely different and it's set in the sclerotic stroma, and your differential, if it's shaved, is going to be the top of a basal cell versus the top of a MAC or something like that. So this is what it looks like, and immediately you might say, oh, it looks like a basal cell, right? Because it's blue. That's because things like that are blue. And here you're going to see that your stroma splits from your stroma. So follicular adnexal neoplasms have a fibrotic stroma that grabs to the tumor, and the stroma will split from the surrounding collagen. Whereas in a basal cell carcinoma, you have a fibromyxoid stroma and the tumor splits from the stroma, okay? So looking in closer, so first of all, from low power, I'm like, oh, this is probably a follicular adnexal neoplasm because this stromal pattern is kind of striking. But then going in closer, you see, can you appreciate this like semicircular, almost horseshoe that reminds you of the matrical portion of the hair follicle? This is too well differentiated to be cancer because it's like trying to make real structures. So there's a papillary mesenchymal body. Here's one that's not as faded, another blue tumor. We can see that the stroma is splitting from the stroma again. And then when we go up close, we can see, you know, these little areas, they don't make here as good of little horseshoes, but they kind of vaguely remind you of these cells surrounding these little blue palisading areas of the matrical portion of the hair follicle. Okay, so it's supposed to remind you of this part. Here's a desmoplastic trichoepithelioma. So on top, it might look more infundibular with little cystic portions, and then going down, it might look more blue. And then you're not going to see papillary mesenchymal bodies so much. It looks more like this. I mean, I guess here it sort of resembles it, but what separates this from a basal cell carcinoma is very much behavior, really, because it can be hard to tell just by the cells what you're dealing with. So if you get a punch biopsy, you see it goes to the bottom, and all of it has got this more sclerotic stroma, and you know your cells are fairly monomorphous like this, then you're dealing with a desmoplastic trichoepithelioma. But you know, if it's very angulated and you get this more fibromyxoid background, then sometimes you have a hard time telling the difference between that and a basal cell carcinoma, and they end up having to excise it. So here, these are often like dimpled or umbilicated papules, right? So this is the epidermis getting pulled downward. Here are your little cystic structures. These are even ruptured with granulomatous inflammation around the little cystic structures, and then these little angulated nests. And then you can see that the tumor ends right here, right? It has this fibrotic stroma that kind of encases it. See that? And that's a desmoplastic trichoepithelioma. Again, cystic structures. See, here's a granuloma because they can rupture. Little granuloma, little basaloid epithelial structures. This is a basal cell. You see it's got this slightly more blue edge, but it can be pretty hard to distinguish them. All right, so what's a trichoblastoma? Well, a trichoepithelioma is sort of like a subcategory of a trichoblastoma. This is like the most immature type of follicular basaloid-based neoplasm that you get to before you kind of transition to carcinoma. And a lot of this was determined by clinical behavior. And so we'll learn the features here, and that will be kind of the last edge before you hit cancer. So it's more immature than a trichoepithelioma in that you don't make recognizable follicular structures. You don't make that papillary mesenchymal body anymore. You basically have a blue ball that looks like basal cell, other than the fact that the stroma is wrong. Okay, so you still have that stromal pattern where it's fibrotic, it sticks to the tumor, and it splits from the collagen around it. A lymphadenoma, which is a terrible name, is a version of a trichoblastoma that has lots of lymphocytes in it. And it's actually the more common pattern that I see. So lymphadenoma is a trichoblastoma with lots of lymphocytes in it. Okay, so here's a trichoblastoma, blue balls in the dermis, right? Looks otherwise just like a basal cell, except you're noticing, hey, wait a minute, this stroma is separating from the collagen around it. It's not separating from the tumor like it does with basal cell carcinoma. And then you go and you're like, well, I see two cell types. I see these blue epithelial cells, and then I see these little black dots, which are my lymphocytes. And then I kind of get the sense that, well, why do you get all this white space? It's kind of like lymphocytes in the epidermis. It causes spongiosis and edema, and so I think that's why it's got that white-looking space. But this has got this weird name, lymphadenoma, which is a trichoblastoma with lymphocytes. And look at your beautiful stromal separation here. Okay, here's another one. Blue balls, kind of looks like basal cell, but wrong stroma. All these little pale areas because they're chock full of lymphocytes. Okay, lymphadenoma. Here's an up close. See, your cells are pulling apart. You've got all the space and edema, lymphocytes, and then basaloid cells. So here's compared to a basal cell. So here you get a little clefting of the tumor from the stroma, and that's compromised by that myxoid, type of stroma, whereas here it's more fibrotic. So what is basal cell derived from? We think basal cell carcinoma comes from the bulge of the hair follicle. So remember that hair follicle from the alopecia section, the hair follicle goes up and down, and when it goes up that little ladder, the bulge kind of reforms your next follicle, probably feeding like the matrical portion that then goes back down the ladder. So the stem cells give rise to the basal cell carcinoma, and then, the actual matrical cells give rise probably to the trichoblastoma. So panfolliculoma, this name actually describes what this is. You could put it in the cyst category or in this follicular neoplasm category, but basically you have follicular differentiation and overdevelopment of all portions of the hair follicle, making it pan, right? You have some trichoblastoma, matricoma, you have overgrowth of the infundibular and isthmic parts. So here's the cystic portion of it. And then here's all the basaloid islands, that's the matrical part that's overgrown. But then you also have overgrowth of the infundibular, isthmic area. You might have a little bit of sebaceous differentiation here. So you see there's overgrowth of all levels of the hair follicle, but not making immature little baby follicles the way the trichofolliculoma did, right? That one was more organized. They were more mature, recognizable structures. These are like tumor-like proliferations of each portion of the hair follicle. Okay, looks like basal cell, wrong stroma. Pilomatricoma, again, this could be in the cyst category, but you could also put it here where you have now a cystic structure that comes from the matrical portion of the hair follicle. And the matrical portion of the hair follicle does not cornify, right? It doesn't make cornified cells. It's supposed to make, feed into like an inner outer root sheath that makes in hair shaft. So you get these shadow cells instead. So here's the blue cells. That's what the tumor is derived from, is the blue cells, the matrical cells. And then what are these shadow cells we talk about? Well, they're just the blue cells that have died, right? This is like the equivalent of parakeratosis, and then the nucleus leaves, and then you have the dead cell. It's not actually like normal keratin the way something keratinized. See, these are the levels of development, dying dead. But this is the tumor cell, or the cyst wall cell, okay? What is a tumor of the follicular infundibulum? This is a kind of a poorly named entity, because if you think about it, using the word tumor makes you think it should be malignant, but this is totally benign. And if you think of an overgrowth of the follicular infundibulum, that really should be like a seb. But the difference between this and a seb is actually that this is more of like an isthmic epithelium rather than an infundibular epithelium like the name would suggest. So it's this plate-like reticulated proliferation of pale cells that kind of just looks like a seb, but the cells are a little bit too pale, okay? You can see it in these various syndromes, which is why we even talk about it. So look from low power. You're like, oh, well, it kind of looks like a seb. It even has a horn cyst. But when you go in close, you can see that the infundibulum is this color. So if all of this part looked like this color, you would really have a seb. But you can appreciate that these cells are slightly plumper and slightly pinker. And if you go back to the slide where we talked about the different areas of the follicle, you would see that slightly plumper, slightly pinker is the isthmic portion where the sebaceous lobules and the pilorector muscles insert. So that's it, okay? Tumor of the follicular infundibulum, people like to call them TFIs, are like the seb-like growth of the isthmic epithelium, not really the infundibular epithelium. Okay, here's up close. See a little rounder, a little pinker. They're kind of cute. Okay, so other than basal cell carcinoma, what other follicular carcinomas do we have? Well, we can have carcinoma from the, if we have it from the infundibular portion, it'll look like a set, it'll look like a squame pretty much, right? If we go down towards the tricholemal portion, then we can have tricholemal carcinoma. So here's a tricholemal carcinoma. So a tricholemoma, for all intents and purposes, is a wart that has tricholemal differentiation. So tricholemal differentiation is that piano key area, that pale area, right? And these can often look like, when they're pale, they could look like just a clear cell squame. And I think that a lot of clear cell squames have been wrongly called tricholemal carcinomas in the past. But this one's like a true tricholemal carcinoma because you actually have the whole warty shape and the pale nature of the cells. But when you go in close, you get a little bit too much atypia. Look at those prominent nucleoli. You get large areas of necrosis. Here's some atypia. But you can see that you have that pale tricholemal differentiation. Okay, here's a little bit more, and you can see the atypia of the cells. So tricholemal carcinoma is just a neoplasm derived from the tricholemal portion of the follicle that is malignant. Matrical carcinoma, so now instead of the basal cell carcinoma, which technically comes from the bulge, now we can have a matrical carcinoma. And these can be really hard to distinguish without stains. And they can have a lot of cytologic atypia, but the immunostain beta-catenin can help you identify that you have a matrical carcinoma. But when you're looking at something like this, how do you even think of a matrical carcinoma? Well, it's hard. You know, you're going to think of something epithelial, hopefully, right? These cells hold together as if there's desmosomes. Probably doesn't look like a lymphoma. I don't see vascular stuff, don't see muscle stuff, so probably epithelial. And then when you look, and it's very blue, but it doesn't look quite like a basal cell. It could be a poorly differentiated squame. But when you look in some of these areas of necrosis, you kind of can appreciate that there's a little bit of this shadow cell stuff going on. So it reminds you of the way that pilomatricoma kind of differentiated, right? Except that these cells are all really ugly. That's the only way to start thinking, oh, could I be dealing with one of these rare matrical carcinomas? And then you do some of the stains. Okay, enough on follicular. So now we go to sebaceous. A lot of people don't agree on how to define these. And so, but I'm gonna just kind of go through basic framework of things that most people would agree on. And then I think that you won't be tested beyond that. So first you have ectopic sebaceous glands and sebaceous hyperplasias. These are not neoplasms, right? If you have sebaceous glands on your lips or genitals, they're called Fordyce spots. You know, on your breasts, they're called Montgomery's tubercles. You know, on your face, sebaceous hyperplasia is just, you know, what we see in fair-skinned people with too much sun exposure. So this is mucosal epithelium. You can see it doesn't cornify. It's got a little extra glycogen. So mucosal epithelium, you wouldn't normally expect sebaceous lobules, but here they are, ectopic sebaceous lobules. You can see they're not even inserting into hair follicles like they're supposed to, right? Because you don't actually have hair follicles in this mucosal epithelium, but this is what a Fordyce spot looks like. I think I'm trying to show here that you have a little bit of smooth muscle. Here, you have a large sebaceous lobule and no real follicle in sight. So this is an overgrown sebaceous lobule, sebaceous hyperplasia. Okay, so those are like normal sebaceous glands that are overgrown or in the wrong place. Then we move to sebaceous adenoma. This category is a little bit controversial because some people lump a lot of different things into sebaceous adenoma category, and some people parse out what they think are associated with cancer syndromes like Muir-Torre from true sebaceous adenomas. We're not going to get into that. Basically, if you have more than one layer of the basaloid germinative layer of the sebaceous lobule, and it's kind of overly proliferated, more so than that sebaceous hyperplasia, then you think about a sebaceous adenoma, okay? So look at our normal sebaceous lobule. You have one layer of the blue cells, which are the germinative cells, and then mostly these mature sebacites. In this one, you can see that you have more overgrowth of this blue germinative layer, like 2 layers, 3 layers, and then they still are making mature sebacites. Architecturally, this still resembles, you know, how you think sebaceous lobules should be, either in a sebaceous hyperplasia pattern or not. But they tend to insert straight into the epidermis, which is a little bit unusual, right? But it still vaguely resembles a normal sebaceous lobule. That is kind of generally what people agree can go into a sebaceous adenoma category. See, mature sebacites have these little white circles, little white fatty bits in your sebaceous lobule. A sebaceoma, on the other hand, is more like a blue tumor. Okay, it doesn't necessarily have the architectural shape of sebaceous lobules, like a blue tumor where it's like 50-50 blue cells, 50-50 mature sebacites. And you can see little cysts, you can see little duct-like structures. Remember, sebaceous glands are ducts. So here's more of like a blue tumor. And if you count it out, you're at about 50-50 blue cells and white cells, but they should all be, you know, they should all be normal cells. If you go in and you look at your sebacites, they should look vaguely normal. Your little white circles, they shouldn't have crazy looking nuclei. And then your blue germinative cells should look monomorphous, meaning they should all look like each other. Here's another look. Here's your sebacites and your blue cells. Sebaceous carcinoma, you can have eyelid type and non-eyelid types. They could be very blue, where all you see is, you know, just a couple little mature sebacites to tell you it might be sebaceous, or they could look kind of like that sebaceous adenoma, but have a lot of atypia in them. And this one, see, it kind of has that shape, but it's a very blue tumor. But when you go in, you can see these mature sebacites, and that tells you it's sebaceous. But when you look at the blue cells, you could see, oh, these are very atypical. There might be extra atypical mitotic figures, etc. This is cancer. Okay, this is sebaceous carcinoma. Okay, let's move on to ductal tumors. So ducts are lined by these more cuboidal epithelium, right? As opposed to the follicular things are either blue basaloid palisaded, or they're piano key, or they're epithelial, like epidermal looking. So these are cuboidal looking, and they either can be apocrine with this decapitation secretion, or they can be ecrine and have kind of these 2 layers of very even epithelial cuboidal layers. They're filled with fluid, right? This is what fluid looks like, as opposed to keratin, which is what follicles make. So apocrine gland, ecrine gland, as a reminder, okay? So hydrocystoma, this is not a neoplasm, it's just a cyst, but it's a cyst lined by 2 layers of epithelium. And people have argued in the past, oh, is it a apocrine hydrocystoma or an ecrine hydrocystoma? And then some people are like, I think they're all apocrine, but sometimes they're so filled with fluid, it squishes it and you can't see the decapitation secretion. I say, who cares, right? I'll never try to distinguish them for you. A hydrocystoma is a cystic, you know, dilatation of a sweat gland. And I think they're probably all apocrine, but I'm not gonna wade into the fray on that. So here is a hydrocystoma. Probably when it was filled with fluid, it was a nice round circle, but then when you shaved it some of the fluid leaked out, and now it's like a deflated balloon with this jagged edge, okay? You see your nice cuboidal epithelium, you see some nice decapitation secretion, and your fluid. All right, syringoma. Now this is a little more complex. You've got your ductal lining, 2 layers of cuboidal epithelium. This we mostly agree is eccrine lesion. Sometimes they have a little small tail, so it's on your Paisley tie differential, and it has a dense fibrous stroma. That's what's noteworthy about it. So here are 2 layers of cuboidal epithelium filled with fluid. This is probably the least impressive dense fibrous stroma I've seen, but I don't know why. This is just an old photo that I have in here. It's usually encased in dense fibrous stroma. That kind of tells you that this thing is benign. Okay, just so you don't worry you're on the top of a Mac or something like that. 2 layers of cuboidal epithelium filled with fluid. If they're really pale, so like a syringoma with clear cell change, we see those in patients with diabetes. All right, cylindroma. Cylindroma is where you get islands of basaloid cells, and they're surrounded by this pink hyaline band. So whereas follicular tumors tend to have this very fibrotic stroma, so red with lots of fibroblasts, ductal things tend to have a lot of hyalinization around them, so very pink, hazy stuff. And it might be very edematous and vascular, or just kind of dark pink. Your peripheral cells can palisade, so a lot of times people have a hard time telling if they're dealing with a follicular or a ductal structure here. You can have this jigsaw puzzle look, and it has a lot of overlapping features with spiradenoma. So we see, you know, in our syndromes that we talk about this, like Burke-Spiegler, they can have cylindromas or spiradenomas. Well, in the same lesion, you can see features of a spiradenoma, which is more like this version in a blue ball versus this version in jigsaw puzzle pieces, okay? So this one looks more like jigsaw puzzle pieces. As you can see, it's very blue. You're like, oh, well, how do I know that's not follicular? It even has a little bit of the separating stroma, which doesn't help. But when you go in close, you get a lot of this very, very pink hyalinized stuff. And if you look even closer, you might see little holes, right? These little holes are ductal structures. So this is a cylindroma, and it is a ductal lesion. See the little holes? Spiradenoma is a blue ball. Might have a lot of admixed lymphocytes. It's kind of like the ductal version of a lymphadenoma, right? And then the stroma can be edematous, a lot of overlap with cylindroma. So if it's more ball-like, then it's spiradenoma. See, very blue again. So see here, it's hyalinized, meaning it's this kind of nondescript, very uniformly pink stuff. And then this, it's all spread out here because there's a lot of edema and blood vessels. Here's all your little lymphocytes set inside it. Here's your little ductal structures, okay? Look for the little holes, the little ducts. These are not blood vessels. These are lined by the same epithelial lining, okay? All right, moving on. So now we're at poroma. Poroma is eccrine, and eccrine cells are very uniform. So you'll see ducts, and you'll see this very uniform proliferation of round cells, and it has a very vascular stroma. So here's our epidermis, right? And you can see where the cutoff is to this very uniform proliferation of round cells. It's almost as uniform as what you might see in like a glomus tumor, which we'll cover in the vascular section. But when you go in close, you can see first it has this very, you know, liquidy center because there's ducts, and it has a very fibrovascular stroma. So a lot of blood vessels, you might get a little hyalinization. So uniform cells. If we go to another section, see, little duct spaces, little duct spaces. This is the stroma, lots of blood vessels in the stroma, very uniform cells. So you could see the desmosomes around them. You know, this is epithelial. And this is how you know you're dealing. If you're like, oh, how do I know if this is a glomus tumor or a poroma? Well, poromas make ducts, and glomus tumors should be attached to blood vessels. All right, anything with the name papilliferum in it has these invaginating areas in the kind of ductal structure. And so a syringocystanoma papilliferum has ductal structures that extend as invagination with multiple villus projections. So we'll see what that means in a second. You can either be lined by columnar or cuboidal cells, and you got lots of plasma cells in the stroma. A third of these occur in association with a nevus sebaceous. So here, this thing, the ductal structures kind of go in and out as invaginations, and they have these little villus structures. And then the stroma is in between the epithelial extensions, okay? So anytime you see stuff like this, you're gonna have the phrase papilliferum in it. The little invaginations, and then here's the stroma, which is again pink hyalinized and vascular, but it's gonna also have a lot of plasma cells. See these little cells, little clock face, speckly nucleus off to the side, cute little plasma cells. Invaginations. Okay, here's another one. Now this one, instead of those little villus projections that stick out, it's these invaginations make more like little maze spaces. But again, this still all qualifies in the papilliferum category, okay? And sometimes you see it in the dermis and it doesn't connect to the epidermis. Oh, I forgot to mention back in the poroma section, hydroacanthoma simplex is when the poroma is only in the epidermis, and dermal duct tumor is when it's only in the dermis. They're all poromas. I'm not a splitter, so, you know, I just talk about them as poromas. So this syringocystadenoma doesn't look like it connects to the epidermis, but depending on where you cut it, it might. So a lot of times people use that as a factor to distinguish from a hydradenoma papilliferum, but I think, you know, you got to be careful. Really, location is going to help you distinguish those. So up close, you see your little invaginations. Okay, so speaking of which, hydradenoma papilliferum, modified apocrine glands that you find in the vulva or the perianal area creates this, as opposed to regular apocrine glands. It looks a lot like erosive adenomatosis of the nipple. So anywhere you have these modified apocrine glands, you can have these same changes and they get different names. It has this arborizing trabecular pattern, just like you have in syringocystadenoma papilliferum. But for some reason, you always get your samples like this with no skin around them. And I don't know how the GYNs manage that. Even derms manage that. But just because it does or does not connect to the epidermis, it's, you know, you can't always use that as a call to distinguish them. But if it comes from the vulva, you know, it's probably safe to guess that it's a hydradenoma papilliferum. Okay, and you can see this apocrine secretion. You probably have a lot of plasma cells somewhere in your stroma. Okay, tubular adenoma. There's a lot of different names for this: papillary ecrine adenoma, apocrine adenoma, or tubular adenoma. Basically, you have tubular or round cystic structures in the dermis. It's kind of like the equivalent of the trichoadenoma for the follicular stuff, where they have cystic things in the stroma. It can be just big cysts, or they can have papillary projections into it, making it a little more complex. Stroma is fibrotic. It can also look like a syringocystadenoma papilliferum near the surface. So here you can see now you have larger ductal structures extending through the dermis. And only because I could see the bottom of this am I not worried it's a sweat gland carcinoma or a MAC or something like this. So, you know, if you get a shave of this, this is a re-excision because somebody was told to re-excise it. And then you can see at the surface, it's a little more complex and looks a little bit more like a syringocystadenoma papilliferum. But mostly you have these little ductal structures. See all these ducts in the dermis. And sometimes they're very large, or sometimes they're small like this. But this is a tubular adenoma. Okay, apocrine hydradenoma, otherwise known as an ecrine acrospiroma, which is the name I learned it as a resident, and then when I became a fellow, I was really confused why I'd never heard of a hydradenoma. They are the same thing. These names are terrible. They were not invented by dermatologists. I will just say that. All right, so it's a solid or cystic tumor in the dermis. Sometimes it connects to the epidermis. And these cells, you know, for the most part, it kind of looks like a poroma, but it's different because the cells are a little bit more polygonal. They're not so round and perfect the way a poroma is. And they can have a clear or an eosinophilic, meaning red, cytoplasm, and you'll see the ductal structures. So here you see this structure in the dermis. You get a lot of the cystic space. You don't necessarily have it. It could be solid, cystic, could be like little aggregates, and you can see it's a more pale cell. And when you look up close, you see the shape is a little bit more polygonal rather than just perfectly round, but it's still ductal. It still has spaces that have fluid as opposed to making keratin. Okay, hidradenoма, often very clear. This is another one. This is a very clear one, and it almost reminds you of like a metastatic renal cell, except that the cells are very benign looking, okay, very, very clear. And this one doesn't have those large cystic areas. It's still a hidradenoma. Okay, what's a mixed tumor? Well, a mixed tumor is when you have both a epithelial tumor element and a stromal kind of tumor element, and they're both kind of equally prominent. And so when we talk about apocrine mixed tumors, we're talking about the epithelial component being apocrine, in which case it's usually elongated branching ductal structures in a myxoid or chondroid stroma. And the ecrine one tends not to be branching. It's like more little circles, just like how the ducts are in real life, little circles, like little flowers in a chondromyxoid stroma. So here, this is a mixed tumor. You can see a very prominent kind of bluish chondroid background, and then this ductal element that's elongated and branching. This is an apocrine mixed tumor, okay? And then this is another one. See, chondroid stroma. You see how well defined it is by its stroma? This is like a marker of being benign, is this well-defined stroma. You see these ductal spaces making fluid, and they're elongated and branching. So this is another apocrine mixed tumor. Going in, you can see the stromal component and the ductal component. See the fluid, the chondroid stuff, little decapitation secretion. This, on the other hand, is an ecrine mixed tumor. Okay, and then now look, you can see the little ecrine coils are more like circles rather than those long branching ducts. Some people refer to all of these as a chondroid syringoma. I technically don't like to use that term for both of them because syringoma really applies to ecrine things, so I would only use chondroid syringoma for this and not the other one. But if you use the term mixed tumor, then you're correct all the time, okay? All right, so what are some malignant sweat tumors? Well, first you have Paget's or extramammary Paget's. So Paget's is truly an adenocarcinoma of the breast. It's not really a sweat gland, although breast tissue is modified apocrine tissue. So I'll show you a picture of Paget's, and then extramammary Paget's. It's usually from the underlying sweat glands, but sometimes you can have, you know, extension of tumors from nearby organs, like, or even like rectal carcinomas or different GI things can extend into your skin and make extramammary Paget's. You get these large pale mucin containing cells in the epidermis. They scatter upward in the epidermis, and that's where the name pagetoid comes from. Okay, and there's CK7 positive, CK20 negative cells. So this is a breast carcinoma that's involving the epidermis. It's like a true Paget's. You see it's ductal, these round structures that make ducts, and then these cells are sort of hard to see, but you can see this epidermis is disrupted and these cells are kind of skipping upward in a pagetoid fashion. This is what we more think of when we think of extramammary Paget's, because we deal more with cutaneous things like this, and you can see these are mucin containing cells. When they're in the basal layer, they tend to squish the cell below them, and that helps you distinguish these from melanoma. Usually melanoma is pretty confluent with bad cells, and then it skips upward, whereas these are kind of scattered throughout. And the ones at the bottom are often not truly on the bottom. They're squishing the cell below it. And they're filled with mucin, which other things in the pagetoid differential usually aren't. So here's a Bowen's disease, right? It can be very pagetoid. Here's extramammary Paget's, and here's melanoma. See, it tends to be more nested or more confluent, and then it has that upward skipping. So it can be hard to tell, and we do stain these often just to confirm. Porocarcinoma. Porocarcinoma is a malignant version of a poroma. So similar architecture of a poroma, but with atypia. So far away, you have these ductal structures, right? And it looks overall like a poroma. You've got this hyalinized pink vascular stroma. And when you go in, your cells are kind of monomorphous, except when you go in even closer, you're like, oh, well, these don't look normal. They vaguely look like they want to look normal, but they're an atypical version of them. So this is a porocarcinoma. This is something that you don't need to know, but I just include it here for completeness sake. This is a kind of recently described lesion called an endocrine mucin producing sweat gland carcinoma, which is an awesome name. And sometimes people refer to it as an EMPSGC. Sorry, EMPSGC. Anyway, it's a low-grade eyelid tumor. So if you see a little tumor near the eyelid, it could be this sweat gland carcinoma. And the reason they're kind of special is because they can express hormones such as ERPR, chromogranin, synaptophysin, and they can be solid or cystic, and they sort of recapitulate breast tumors, but near the eyelid. So here's one that has these large cystic areas. They can also be sitting in pools of mucin, which breast tumors can also be, and the staining pattern can be similar. You can see it's ductal, it's pretty well circumscribed, so these are low grade, but when you go in close, and you can see it's making fluid, but when you go in close, you can see that these cells are atypical. Sorry, the staining, when I meant endocrine, I meant neuroendocrine. So chromogranin and synaptophysin are neuroendocrine stains that we see in like a Merkel cell carcinoma, for example. Okay, so here's a hidradenoma. This is benign. You see how uniform each cell is. You can see the cell border on each. And this kind of looks similar, but the cells are jumbled on top of each other. The nuclei are a little large and a little dark. Okay? Microcystic adnexal carcinoma, this is something that we kind of see more often than not in the skin. And one thing that can distinguish it is that it's not well differentiated. So sometimes you see both follicular and ductal differentiation. You're seeing keratin and you're seeing ductal stuff on a shave. You better worry that you're looking at a MAC. These extend deeply. They can have a fibrotic stroma, but your fibrotic stroma is probably not as well defined, like it's encasing the lesion as in benign lesions, and you often see perineural invasion. So you can see through here all the way down into the fat, you have these little ductal structures that invade. And if you get a shave, it's really hard to tell that this thing's bad. But look in here, you see this keratin. And then if you look over here, you see ductal structures with fluid. So you'll see that mixed pattern. And you see how the stroma is not really prominent because cancer is invisible. It tends to invade through the collagen very easily. There's the keratin, there's the ducts, and it kind of comes all the way into the fat, might even go into the fat, and then it wraps around nerves. So this is cancer. This is a microcystic adnexal carcinoma. And you can see why sometimes if somebody shaves a desmoplastic trichoepithelioma, you might worry that this is on the differential, okay? But this is a much more fibrotic stroma, and this one doesn't have any ductal differentiation. And finally, a digital papillary adenocarcinoma. I'm sure your eyes are glazed over. This is my least favorite topic, but in an effort to be complete, we will cover it. So digital papillary adenocarcinoma is basically on your digits, right, near your fingers. You can get this sweat gland carcinoma. That's bad. And the word papillary is in it again, right? So you're going to have those papillary projections surrounding a cystic space, and you get variable amounts of atypia. So this thing's really well circumscribed again. So that kind of makes you think maybe it's benign. But if you get a big blue tumor like this on a digit, you got to be really careful. This area is this kind of large cystic area, but it might have a lot of necrosis. And this is those papillary projections that give it the name papillary. But when you look up close, the cells, you see how they're jumbled on top of each other. They don't lay next to each other properly like they should. Here's that hyalinized border, that really smudgy pink border we see around sweat gland things. You know, we have areas of necrosis that are not truly like ductal structures, and that's something that you see in cancer that grows really fast also. Okay, so that's it. Kind of an introduction how to approach follicular and ductal neoplasms, and otherwise you're just going to have to memorize it. Hope that was helpful. Until next time.